Okay, looking at some more in regards to the scapulothoracic joint. So we have our motions that we get at the scapulothoracic joint. It's important to remember that these motions occur because of what happens at the AC and SC joints. So the AC and SC joints are what basically contribute to what motions happen here. So just some things about the motions. We know we obviously have elevation and depression. With elevation and depression, you do get larger movement at the SC versus the AC joint. So the SC joint will take on a larger range of motion when you do elevation and depression versus some of the other motions. We have protraction and retraction. Again, when you're looking at your planes and axes, your protraction and retraction will take place in the transverse plane along a vertical axis. Upward and downward rotation, which will take place in the frontal plane around an anterior-posterior axis. So these are some of the motions, and again, thinking about some of the planes of motions and the axes that they take place around. And it's important to look at, and we're going to see the relationship here when you look at elevation of the arm. So start thinking about what the scapula has to do in order to maintain position, in order to maintain stability at the glenohumeral joint for function of the humerus when going through the range of motion. So now looking at the glenohumeral joint, we look at the classification, the degrees of freedom. So we have obviously a diarthrodial joint. It's a ball and socket joint with 3 degrees freedom of motion. So think about what the 3 degrees means in as far as the shoulder, so what motions take place there. When we look at the orientation of the glenoid, primarily what we look at with the shoulder, so we have two big ball and socket joints in the body, or the glenohumeral joint and the hip. And the interesting thing to know, while they both have 3 degrees freedom of motion, the shoulder, the glenohumeral joint, is much more mobile. Now that mobility comes at the expense of stability. So there's not a whole lot of bony stability at the glenohumeral joint. Primarily when you're looking at the glenohumeral joint, you're looking at the soft tissue structures essentially around the glenohumeral joint, providing most of the stability. One of those structures is the joint capsule. So when we look at the joint capsule, obviously it's made up of the different glenohumeral ligaments. So we have the superior, the middle, and the inferior glenohumeral ligaments that make up the shoulder capsule. And there's some things to note about that. There's a spot in the capsule where there is a weakness. It's referred to as the foramen of Whitebrick. And at that point there is a little bit of weakness there, so sometimes that could many times contribute to a lot of instability, and a lot of times where you have your anterior dislocations occur. In looking at the other ligaments, there's one of the ligaments is considered by some to be the main stabilizer. So I would ask of you to think about which one of those that is. So one of the glenohumeral ligaments is considered to be a primary stabilizer of that region. And another thing is looking at some areas underneath within the shoulder joint, the coracoacromial arch and the subacromial space. So these are 2 areas around the shoulder. Probably when we look at from an injury perspective, the subacromial space is very relevant. So within the subacromial space, you have the supraspinatus, the biceps tendon, the subacromial bursa, and the superior joint capsule. And we all know that the subacromial space is not a very large space, and many times this is where a lot of pathological things do happen within the shoulder, particularly when there's some type of overuse or strength issue that does take place. Now, some of the characteristics as far as the range of motion of the glenohumeral joint, First of all, you have your joint end feels. All the joint end feels, all the normal joint end feels for the glenohumeral joint are going to be firm. Even if you do get some contact between the humerus and the acromion process in certain positions in the range of motion, even though you do get some contact there, you're still going to end up getting firm end feels. Okay, and again, most of the firm end feels around the shoulder are going to be because of the either muscle tightening or the tightening of the joint capsule. I had mentioned the subacromial bursa, which is obviously an important one to know. There's also a subdeltoid bursa, so there's a bursa that sits right beneath the deltoid muscle as well. I want you to think about and look at the range of motion that occurs with the different movements at the shoulder. Now, obviously we have our ways of measuring the actual range of motion that takes place around the glenohumeral joint, but sometimes functionally when we look at what can take place, it depends on position of the humerus. So you can see this for yourself. So if we just simply look at abduction, abduction, your motion that you do is going to really depend upon how your humerus is positioned. For instance, if you were to just in a standing normal position medially rotate your glenohumeral joint as far as it can go and then abduct, you're going to be limited to about 60 degrees range of motion in abduction. So again, if you just medially rotate and try to abduct, you're going to really be limited to about 60 degrees range of motion. If you laterally rotate about 90 degrees and you come up, you will get a little bit more with range of motion, but you're only going to get to about 90 degrees of abduction, because basically you're going to end up creating a situation where the deltoid runs into active insufficiency. So again, go into lateral rotation, try out abducting, you get to about 90 degrees. If we're looking at just pure passive motion into abduction and we have the scapula stabilized, you'll get about 120 degrees passively, and really the tension at that point is going to be brought on by the inferior glenohumeral ligament, is going to prevent any more motion. Obviously, if you don't stabilize the scapula, you'll get greater motion out of that. A lot of them too, that transitions to talking about that. If you don't stabilize the scapula, obviously you'll get more motion, because the scapula is what basically is going to permit that. If you do stabilize the scapula, obviously because of the capsule tightening, you won't get as much range of motion. So it really just depends on if you're stabilizing the scapula to look at range of motion, or if you're allowing the scapula to move freely. So, for instance, when we look at shoulder flexion, if you're looking at just pure shoulder motion, you will pretty much be looking at about 120 degrees if you're not accounting for scapular motion. Okay, obviously with scapular movement you can pretty much go the full 180 degrees with that range of motion. Looking at the open and closed packed positions, so the open packed position for the glenohumeral joint, so where you're going to get the most amount of arthrokinematic motion, is 20 to 30 degrees of horizontal abduction and about 55 degrees of flexion. So that's going to be the position where you get the most amount of mobility at the glenohumeral joint. The closed packed position is full abduction and lateral rotation. So full abduction and lateral rotation is when all those soft tissue structures will be wound rather tight and you'll have your least amount of arthrokinematic motion. Another important thing to look at is the concept of scaption, or movement in the scapular plane. So some of this was alluded to earlier, but about 30 to 40 degrees from the frontal plane is what we have called scaption. And within that region, you do tend to get a little bit more motion, and we had talked about the concept of scaption. When you get glenohumeral abduction within that 30 to 40 degrees anterior to the frontal plane, you really get to see the capsule in a loose pack position, and there's less of a chance of getting impingement when you move in this motion. So for instance, we do like a lot of just functional movements without even realizing it in the scapular plane, just because it's a little bit more functional. We also, when we look at movement just for rehabilitation purposes, we do tend to do a lot of exercises in here just because it's a little bit easier on the rotator cuff. So now we look here at the arthrokinematic principles that occur at the glenohumeral joint. So we obviously know that, primarily a lot of open chain motion, and with that at the glenohumeral joint we have the convex humeral head moving on the concave glenoid. And pictured on this we have abduction and lateral rotation occurring. So you see abduction on the left, lateral rotation occurring on the right, and what's going on as far as the roll and slide characteristics. So on the left we have abduction, and again, kind of orientate yourself. Look at what we're looking at, superior and inferior here. So with abduction you have a superior roll and an inferior slide occurring as abduction is happening. Okay, so obviously with adduction we would have just the opposite as far as the roll and slide occurs. On the right we have lateral rotation. So with lateral rotation we have a posterior roll and an anterior slide. Okay, so we have those roll slide characteristics. And again, we could also look at this in class too, just to make sure we clear up any confusion. So we have the examples of abduction and lateral rotation. Obviously with adduction and internal rotation or medial rotation, you would have just the opposite occurring. And you could also see they're actually showing you what's happening with the joint capsule with these motions. So you could see with, for instance, abduction, you're getting a slack of the superior capsule occurring with a tightening of the inferior capsule. Now we don't have flexion and extension shown. Flexion and extension is kind of different arthrokinematically in that primarily actually what you have happening with pure flexion and extension is actually primarily spin occurring. So remember we had talked about spin being one of those arthrokinematic motions. So it's actually one of the situations where you do get spin occurring. However, you do get, so for instance, when you have flexion, okay, so if you flex your shoulder, again, obviously you primarily have spinning, but you do get a slight amount of anterior slide at the end. So at the end of the flexion range of motion, you do get some anterior slide, and at the end of extension, you do get some posterior slide. So again, flexion, extension, primarily spin. At the end range of motion, you do get a slight amount of sliding occurring at the end. So in looking at some of the passive stabilization at the glenohumeral joint, so we know that as a ball and socket joint, the structure of the glenohumeral joint doesn't really lend itself inherently with the bony stability to provide a whole lot from the structure, because if we just look at the glenohumeral joint, there isn't a lot of bony stability there. A lot of the passive stabilization that occurs happens through the ligaments surrounding the actual joint itself. When we look at the SC and AC joints, their stability at rest is completely provided by the ligaments. Okay, so the ligamentous structure there is very important at the SC and AC joints. As we see with the glenohumeral joint, obviously there's ligaments that do provide. When we look at the glenohumeral joint stability at rest, you have the ligaments that provide the bulk of the support at rest are the coracohumeral ligament, the superior glenohumeral ligament, and the other thing that provides stability to the glenohumeral joint at rest is the negative atmospheric pressure in the capsule. So there's a negative atmospheric pressure in the capsule that further helps to kind of provide some stability at the glenohumeral joint. Okay, so again, SC and AC joint at rest, ligamentous primarily. There is ligamentous support at the glenohumeral joint, but as you'll see when we talk about, it's actually the dynamic stabilizers at the glenohumeral joint, that referring to the actual muscles around the glenohumeral joint that do provide just the bulk of the stability in general. And then when we just look at the scapula and clavicle itself, most of the stabilization comes from just the scapula and clavicle resting on the thorax. So actually kind of resting on the rib cage, if you will, is where those two bony structures just basically provide their stabilization. So dynamic stabilization, so the SC and AC joint, as we talked about previously, really the bulk of their stabilization comes from the passive stabilizers. When we look at the scapulothoracic and the glenohumeral joint, while the glenohumeral joint does have some passive stabilizers, and obviously the scapulothoracic, because of the connection with the clavicle at the AC joint, does have some passive stabilization there. The bulk of the stabilization for the scapulothoracic and the glenohumeral joints both come from the dynamic stabilizers, and we're going to talk a little bit about some of the actions of that here. So some significant things to look at: the upper trap is a muscle that is really at rest, even very active, just to kind of help support the weight of the shoulder girdle at rest. Obviously, we run into situations pathology-wise where some people do get overactive upper trap muscles, and we'll discuss some of that and work on some of that in class as to some of the issues associated with that. The rotator cuff, while we know that the different portions of the rotator cuff that do have different muscle actions, really the primary role of the rotator cuff is as a dynamic stabilizer of the glenohumeral joint. And as far as the resistance that it's able to kind of work through, really it handles loads up to 25 pounds. After that, you need significant deltoid activation. So, the significance there is obviously, like when you're strengthening the rotator cuff, really you should be strengthening it with light loads, just because after a while, even someone with a strong rotator cuff, you start to get loads over 25 pounds, you're then going to start to recruit the deltoid muscle a lot more. The biceps brachii, even though we typically consider the action of the biceps brachii at the elbow, obviously it is a weak shoulder flexor when we look at it from a movement perspective, but the long head of the biceps brachii provides some anterior stabilization to the glenohumeral joint, so it does provide a stabilizing function with that as well. And an important thing to kind of note, and it's illustrated here in the pictures on the slides, very important and for normal movement and function of the glenohumeral joint, the interaction between the deltoid and the rotator cuff. So if we look at movement of the arm, the deltoid at the beginning of the motion, so we'll be referring to shoulder abduction here. If it was just really the deltoid pulling the shoulder into abduction, you have a lot more compressive forces underneath the subacromial space occurring. So there's be a significant shearing force basically taking place. If you look at the force vectors as to what would happen if we were just using the deltoid to abduct the shoulder, to elevate the shoulder, The humeral head translation is actually prevented by the rotator cuff. So the rotator cuff muscles actually act when abducting or elevating the shoulder to kind of keep the humeral head depressed a little bit more so that you don't get those compressive forces. So even though you do get a small rotary component from the deltoid at the beginning of motion, most of the motion, if you're looking at, again, just abducting, elevating the arm from a neutral position, is going to be directed to more of a shearing force, which is going to cause compression underneath the subacromial space. And again, we see this in pathologies. Individuals with weak rotator cuffs develop shoulder impingement partially because they don't get that interaction between the deltoid and rotator cuff when they elevate their arm. So we began kind of talking about, just briefly, some of the interaction between the scapula and the humerus and the movement that occurs. So looking at scapulohumeral rhythm, now your textbook does go over, through studies, they found different variations in the ratios. For all intents and purposes right now, we're just going to kind of approach it from this perspective, looking at the kind of early stage, if you will. So the first 30 degrees of abduction or elevation, we look at the early range of motion as being the setting phase. Okay, so meaning that as the humerus begins to move, you initially don't really have any motion of the scapula occurring, okay, in the first 30 degrees of motion. After the first 30 degrees, you get a 2-to-1 ratio, meaning that for every 2 degrees of humeral motion, you get 1 degree of scapular motion. Okay, so that's pretty much what we're looking at. Again, you look at some of the studies as they're talked about in the book. They kind of do give some variations that do occur, but for our purposes right now, we're just going to look at the 2-to-1 ratio. For every 2 degrees of glenohumeral motion, you have 1 degree of motion occurring at the scapulothoracic joint, with the first 30 degrees being what we'd call the setting phase, meaning that, again, in that first 30 degrees of motion, you have that all coming from the glenohumeral joint, and then after that, kind of getting the overall 2-to-1 ratio. And again, this just contributes. So we look for this kind of functional movement taking place at the scapula to help contribute to functional elevation of the humerus, because obviously if the scapula doesn't move in a good rhythm, that's when you run into situations where, again, particularly getting impingement underneath the subacromial space being probably one of the more common things that you see occurring.